welcome to a collaboration of Critical Care Time, the podcast for everyone who cares for people with critical illness and Pulm Peeps. I'm Dr. Nick Mark. I'm joined today by my co-host,
Cyrus Askin. Good to be here. Thanks, Nick. Super excited to have the Pulm Peeps joining us for this collab. Do you guys want to introduce yourselves?
Yes, thank you, Nick and Cyrus. I'm Christina Montemayor, part of one half of Pulm Peeps, and excited to be here with my other half, Dave.
Hey everyone, this is Dave Farfaro. Very excited for this episode. I remember when you guys told us you were starting this critical care podcast, and I was thrilled, and the content has been awesome, and this has been in the making for months, maybe even a year, so I'm really excited we're doing it now.
Yeah, thanks so much for coming on. This is our first crossover episode, so it's kind of like, The Simpsons meet Family Guy, Flintstones meet the Jetsons, or that episode where Batman and the Green Hornet team up. So it's going to be exciting.
Yeah, I'm not really sure who's who in that analogy, Nick, but I appreciate your candor.
As long as we're not the Flintstones, I think the medical care in Bedrock is probably suboptimal.
Yeah, and I don't want to date us too much, but I don't know that the trainees know who the Jetsons and the Flintstones are anymore.
Oh,
so
no.
we'll have to find up with a better analogy for them.
Should have leaned into the Simpsons and Family Guy more. Hopefully they know that.
Right.
Oh man, that's soul crushing. I guess we'll just end it here and we'll move on because I'm already sad. Okay. So speaking of Bedrock and their lack of great medical care, on today's episode, after a lot of discussion with David and with Christina, we've sort of decided to talk about bronchoscopic emergencies, or emergencies where the bronchoscope can be your best friend. Specifically, we're going to cover situations where really knowing how to properly use that scope can be useful or even life-saving. And this will be relevant for folks that are working both in and out of the ICU. So it should be really fun.
Yeah, this seems like the perfect critical care pulmonary topic to team up on. Do you guys want to add anything to that?
Yeah, I think the bronchoscope in the ICU is this tool that, when utilized, is absolutely essential. And then also, I think it's really scary when you run into a bronchoscopic emergency in the bronchoscopy suite that you weren't expecting, especially that first time. And so having a little bit of a framework of saying, all right, here are the things that I need to think about, here are the tools I have at my disposal, can definitely help when you need to lower your own heart rate in that first initial seconds of something going on.
Great. Yeah, absolutely agree. All right. Well, on that note, let's get into it.
There's a lot of different ways I think we could tackle this, but when Nick and I were sitting down and kind of outlining this and then working with, you guys, I think it made sense to come up with a case-based walkthrough to where we can have kind of a potpourri, if you will, of topics that will be helpful to our collective listeners. And so we've sort of come up with this framework to talk through a few different situations. And, why don't we just start one off right now? And we'll focus here first on placement of the endotracheal tube. So let's say that you're called sort of urgently to assist a colleague in the surgical ICU who's attempting to intubate a 50-year-old man with an airway obstruction due to a laryngeal tumor. Your partner says she can't see anything. She's looking, sphincters are tightening, sweat is beading. This is despite using video laryngoscopy. So, what can we do here?
Yeah. So this is a high stress, high stakes situation that happens not too infrequently, right? When you get into that, can't visualize situation. And even when you're using the right tools, like a video laryngoscope, this can be really, really scary and truly life-threatening. I think the bronchoscope can help you in airways in kind of two ways. The first is the awake intubation in the anticipated difficult airway, where you go into it saying, this is going to be tough. This is somebody with abnormal anatomy. This is somebody with an airway tumor, something like that. And, going in with a plan and using the bronchoscope preemptively can be great there. The other situation where the bronchoscope can save you is as a rescue method in the unanticipated difficult airway. And this is the really scary situation where, you go in, you think you've got it, and then even using a bougie, VL, optimal positioning, etc., you just can't get the view you need. And this is a situation where, I think having skill with bronchoscope and having, a partner, i.e. four pairs of hands, or four hands, I should say, is a big, big advantage.
Yeah, I totally agree with that. I mean, and those situations, as everyone knows who's been in one, are really scary. You can either visualize and you can't pass through, or you just can't visualize and you're already in the midst of it. And so I do encourage that all airway carts now, or airway setup, you know where the bronchoscope is at least. You're not having to run and get it in the middle of a case, so that you have a rescue option. And then I think in those two situations, thinking about whether you're going to take a nasal or an oral approach in advance is really helpful on your checklist of like, okay, here's what I'm going to do if things are failing. Can I bag this person? Can I do an oral airway? And thinking about the nasal and oral approach a lot of times has to do with the patient that you're examining, but also the scenario that you're doing, right? So very practically, to have an oral approach, you need someone where you're going to be able to get the scope through. The scope is going to be safe, not going to be bitten, right? And you're going to be able to manipulate it. For a nasal approach, you need to have someone who has at least appropriate anatomy, right? A nasotracheal intubation is going to be with a much smaller ET tube. And so if you're really worried about this type of ventilation going forward, that may not be your best option. Also, our major complication we worry about there is bleeding in the nose. And so if you have someone who has a platelets of 20, like I'm probably not thinking about this so much. When I actually learned to bronchoscope, it was only through nasal approaches, even on the wake upstairs. And I loved it. It guided me right through the cords. That being said, I did not miss the epistaxis I would inevitably get by having an oral approach. So those are the types of things I like to think about for this patient. Can I prep? Can they nebulize or gargle some lidocaine? We'll talk about that. Can then we gently sedate? Can we put a bite block in? Do I have the time to do that? Or is this going to be emergent? I just need an airway. And in which case I'm going to use a smaller tube, load it up, and kind of go through the nose.
Perfect. Yeah, I think the case we're talking about here is the emergent one, but let's actually sidestep that and talk about the sort of anticipated difficult airway, because I think there's a lot of good stuff there to unpack. So first off, let's say this is going to be hard. You're planning, let's say, a nasal approach. How do you topicalize this person? Like, what does getting ready look like, assuming you have the time?
Yeah, so for me, I certainly love getting as much lidocaine in there as possible, right? And so I think there are a couple different ways to do that. I think you can have someone gurgle viscous lidocaine and topical lidocaine and see if they can spit it out afterwards. It tastes really terrible, but if they are totally awake and they have the ability to do that, that can distribute it. You can have them nebulize lidocaine and sort of distribute it down into the lungs and the airways. I really like that. Then you get a little bit of numbing, maybe at the carina, where it's another big cough point, if they can really do that well. And then finally is like that atomizer or the spray, depending on where you work, there might be different devices. Atomizer actually has oxygen running through it, and then you can sort of disperse that way. Other times it's just a spray that you sort of put in there. And you really want to make sure you're getting into the back of the throat. So the three main cough points I think of: back of the throat, vocal cords, and then carina, right? And so if you can try to nebulize those things, or topicalize those things as much as possible, that's the best. And then, in general, we're talking about lidocaine. We're not wanting to go above a total dose of like our 8 mg per kg here as we're topicalizing people. You will at one point get someone who gets topical lidocaine or benzocaine and then comes in with like methemoglobinemia later on. And so you never want to forget about that consideration and go overboard as you're doing this.
Yeah, I think having seen that from topical lidocaine, I saw somebody in med school who had laser tattoo removal over like his whole back, and then got lidocaine slathered over that, which increased the absorption. So he actually presented with seizures, something you want to avoid. But I think, as a safety measure, just saying, I know that there isn't more than 8 mg per kg of lidocaine in the room means you can't exceed it. It sort of creates a safety block. The other thing that I'll add, just from personal experience, is I used to do this thing with residents where we would have them taste the different meds. Like the pharmacist would bring some of the oral meds just so you could sort of get some empathy for your patients. And I'll just say that iron and potassium taste awful, but by far the most disgusting med is lidocaine. Like I literally vomited from viscous lidocaine. Like I tasted it and I was like, bleh. So yeah, if you can get your patient to do it, great. If they can gurgle lidocaine, go for it. But it's not fun.
Yeah, I think that's a great strategy. You have to try your meds so you know your patients are going through. If someone can I come up with a good way to give potassium so it doesn't taste bad and it doesn't burn through your IV, then please let me know.
It's a pill. It's like this big, It's a horse pill.
Yeah. Right. Sorry.
Okay, so that's a great discussion of topicalization. What about other medication strategy?
Yeah, no. So then I think when we're deciding on what we want to do for our sedation for this patient, what you're really kind of asking yourself is, do I want this person to be awake? Do I want them to still have a respiratory drive where they can be breathing in case anything's going wrong, especially if I'm worried I'm not going to be able to bag mask them? Or am I doing full intubation where I'm going to rapid sequence induce and then paralyze this patient? And so if I'm really worried and I'm not sure I'm going to be able to get this, then going for an awake, intubation where someone is maintaining the respiratory drive, I think is the way to go. My favorite drug for this right now is ketamine. I think that it works really, really well. I think it's a little bit of a bronchodilator, so you get a little bit added effect there. I think people are maintaining the respiratory drive. From the patients I've talked to, and I've tried to talk to them afterwards, it's not the most traumatic experience. It's just so dissociative. It has a little analgesia, and they've told me that they hadn't remembered or haven't had trauma or PIC symptoms afterwards. I think about 1.5 mgs per kg, as my general for this. So if you have a 70 kilogram person, then go on 100 milligrams and just having it there as your push, I think is a great medicine. Do you guys like anything different or in addition?
I love ketamine, and I was gonna ask you what kind of dose you use, because I know there's a pretty decent range. If you're using it for RSI, you might be a little heavier handed versus something like this where you're not totally trying to give them that full dose. I completely agree with you. I love ketamine as a drug for a lot of different purposes, whether it's for procedural sedation or in concert with something like propofol for RSI, or in this particular case, I think it's great. The other drug I really like, and I think most of us probably like to use it, is dexmedetomidine or Precedex, which is great, I think, for, again, a host of indications. Anxiolysis when you're trying to get someone to work with the bilevel, or in a situation like this where you've got like usually it's invariably there are a ton of people in the room, there's a ton of equipment, it's adding to the stress level of the patient, and giving them a little bit of Precedex to kind of chill things out and smooth things over, I think is a really effective strategy as well.
Yeah, sometimes I think if you could put it in the air, it'd be good for everybody in the room.
Nebulized, vaporized,
yes.
and I'll also give, I should say, a milligram or two of Versed, to try to chill things out. Not so much that that's my sedative, but just it's high anxiety for a patient, right? And so letting them anxiolyze a little bit, I think. Really
and the amnestic effects are not a bad thing either. This is generally not a memory that somebody wants to have.
Yeah, 100%. And then you mentioned something, Nick, already that I think is really important to think about, which is how many hands you have there. So I don't know, actually, I'm curious what it's like for you guys out there. I know Christina and I are both on the East Coast, and the culture in a lot of the East Coast institutions is that anesthesia does the intubations in the ICU. That's certainly a culture here. I try to buddy with them and be doing the intubations when I can, but they're available and they're the most experienced operators. And so as the critical care physician, you're often managing the situation around it, and you're maybe another set of hands. And I have one of the anesthesiologists that we work with a little bit on sort of sims for this, and having two operators and another set of hands there, and knowing what that person's going to do if things are not going well, I think is like the real planning for success that comes from these high risk intubations. And the ones that I've seen go really well are where you have a lot of communication, even down to where people are standing, before we start this procedure. Like, hey, could you actually come back here? I don't have a great view, or I'm a little crammed in the back here. Then you can be managing this. And so having that 4 hands, even more, 4 pairs of hands would be great, to try to minimize the unanticipated things that go on.
Yeah, I think you can't plan too much for a difficult airway. Like, you can't over prepare, and like thinking through the nuances of that is great. I think, in this case, we're talking about a situation where like it's an unanticipated difficult airway where you're sort of the second person arriving. And so like, what can you do in that setting? And like, having been in that situation before, one of the things you can do is you can sort of like say, okay, I can see you're working on this. I'm going to get the bronchoscope ready. I'm going to load the tube. I'm going to lube the tube. I'm going to get everything ready on the bronchoscope. And then, either I can hand it to you if you feel like you're in a good position, or if you want to use the video laryngoscope to try to get the view as good as possible, and then I will drive there. And that's like a great situation where, one of the great things the bronchoscope can do in a difficult airway is really make that turn. So like a very anterior airway, a bougie can help, but a bronchoscope is like, it's like
money.
Having x-ray vision. You can see what's around the corner.
Yeah, I love that. I love arriving and assessing where you are, saying, what am I going to add to the situation? Like any situation in critical care, calm and closed loop communication, right? So if the person is at the head of the bed saying, I just need you to come here, take over. Like, I can't see anything. I'm not sure what our next step is. Then that's very different from saying, hey, I can view the cords. I just can't get this thing through. And you're like, great, stay exactly where you are. Keep the cords in view. Our vitals are this. We're coming with the bronchoscope and we're going to make this. And I think that combination of having video DL and a bronchoscope, I mean, that if you can't get it with that, then we really need to be thinking about surgical airway, like right away.
Exactly. And that's something the second operator can also be doing, right? Like, let's say you hand off the bronchoscope to that first operator and you're like, okay, you've got this just in case. Hey, can I get the tray open, find my landmarks, clean the neck, like be ready to go in case your plan B, which is the bronchoscope, fails.
I think those are like all incredible points. And the one takeaway for me is that, like here at our institution, we've initiated or about to launch a code airway team for situations that arise like this in an unexpected manner, or if it's actually like the patient's coming up to the ICU, they have a history of laryngeal cancer, you're anticipating it's going to be a difficult airway, you can initiate it there too. And I think David and Nick and what you guys are really alluding to without necessarily saying it outright is that this is not that dissimilar from a code that we would typically run, where it's an orchestrated effort to deliver fast and effective patient care to ensure everyone is on the same page using closed loop communication. It's to me, this is just as stressful and frankly more stressful than like a code blue, because at that point it's like, if I get ROSC, like the ceiling for success is so low in that situation in some respects. It's like, and you have an algorithm to follow that's very, very clear in a lot of cases. Whereas with airways, it's, different operators have different approaches. And so it is just so critically important, I think, to have the team communicating effectively. And like Nick, like you said, like identify what's going on and then identify what you can do to help things along without getting in the way.
Yeah. I think one sort of interesting sort of clue that can tell you, like to David, to your point about like, is this a take over for somebody or is this a help somebody, is like you look at the face shield that they have on, and like if it's completely fogged up with like condensation, that's usually a sign that that person is like, kind of at like a code red psychomotor agitation state. Like they probably need a break. Right. As opposed to like if crystal clear, there's no sweat on their forehead. Like, okay, I think you got this.
Yeah. Opaque face shield sign. We're gonna
the face shield sign. Exactly. One other point, to make here is that like the four of us here, like we're all pulmonary trained, which means that we all did like hundreds of bronchs in our training. Right. So like we're comfortable with the mechanics of picking up a bronch and that kind of stuff. Even if this is a rare situation that maybe we haven't done a lot of. For people who don't have as much experience with a bronch, it's really, really important to practice and train and to sim these things. It's important for us as well, but just remember that like, in general, people don't rise to the occasion, they sink to the level of their training. And so if you've picked up a bronchoscope once or twice in your career, the time when you really need it is you're not going to be great with it, right? It's probably something that should be part of a simulation curriculum that you're doing somewhat regularly. Otherwise, it may not actually help you that much if it's really unfamiliar and you're like, hey, the thumb does what again? Like, how does this thing work? So practice, I think is a key takeaway. Be ready for the situation before.
Yeah, absolutely. And a plug for when you're learning bronchoscopy of trying to say like, oh, this is a stable patient, I'm outpatient, I'm just going to play around with my techniques, be like, how quickly can I get to the cords? And, and we'll talk about bleeding when it comes up. I had a person who used to make me like go from the vocal cords to a lobe and then come back and be like, all right, now close your eyes and try to get close to that. Just so a couple of things you can say, these are the situations that are coming. And I want to be able to get if I know I always have trouble getting over the tongue and getting to the vocal cords, then maybe I'm going to go for the nose when I have somebody who's in an emergent situation, because that's going to guide me a little bit easier there.
That's a great point. I love that. Like, practice with your eyes closed approach to like learn the anatomy.
We really did a great job there covering, the use of the bronchoscope to get that initial tube placement. Let's move on to another case. Christina, do you have one for us?
Yes, sure do, Cyrus. Yeah, we've had such a great discussion so far, and I think we've highlighted setting yourself up for success. But so a different case. So you're coming on to cover a night shift, and you just got sign out on a patient who had a freshly placed tracheostomy. Everything otherwise is going smoothly, and you don't anticipate any needs for the patient overnight. But of course, nothing goes as planned, and you get a call and a page in a few hours from the room that the patient's trach has come out. Please come to the bedside. You rush to the room, you try to assist, and as you're going to the room, you're starting to think about what you're going to do and what your next steps are. So, how do you approach this, and can the bronchoscope be helpful in this situation?
Yeah, it's a great situation. It's something that I encountered twice in fellowship. Once I think during the pandemic, and once immediately like kind of shortly prior to. And Christine, I'm curious to get your thoughts on this, but I'll kind of tell you how I approached it and what I was taught. A lot of times, especially with freshly placed tracheostomy tubes, you need to realize that tissue is very it's friable potentially. It's also they've not had time to properly cannulate, so you don't really have a proper lumen that has the sort of integrity that you're used to in your chronically trached patients. And so one of the biggest risks, I think, especially in someone who's maybe uninitiated or not as familiar, is you go and you're like, oh, there's a hole. I just kind of put the tube back in the hole. Well, the problem is that it's very possible that in doing so, you can dissect tissue within the neck and actually kind of cannulate what is called a false lumen. So the tip of your tracheostomy tube is actually sitting in soft tissue and not in the trachea. And so my approach, I think in general, again, another stressful code-like situation is first, look at the monitor, check the vitals, see what's going on, look at the patient, look at the room, get your finger on the pulse of both the patient and the room, so to speak, and kind of a lot of times folks are running around, they don't know what they're doing. Or they may know what to do, but in the setting of that sort of extreme stressor, they're not really functioning at the level of their training, so to speak. And so, like for example, I've seen someone getting bagged via the mouth and nothing kind of occluding that new ostomy site. And so, like, what are you really doing there? Or alternatively, maybe someone who's a more junior trainee just kind of sticks the tube back in, and you're like, oh, what's their vitals are still getting worse and worse. They're in extremis. They're becoming cyanotic. So in those situations, usually what I'll do is kind of at the end of the day, intubating from above in a case like that is oftentimes the right move, especially if you don't have a bronchoscope. And if this is like really like, if it's hitting the fan, so to speak, that's one very useful option. And then you can also kind of use that new ostomy site as a means to almost like directly visualize to a certain extent that tube going in the appropriate place. And then of course you're basically in that setting, you're doing RSI and all of those things to try to just get control of the situation until you can remedy it in a more durable way. Now, alternatively, what I've actually done is, I happen to be at the bedside, like within a few seconds of this happening, and my back-to-back set me up for success. So we actually had the ambuscope nearby ready to go. And so, and I had a experienced team of RTs. They had occluded the ostomy site, they had occluded the stoma site. They were effectively bagging that patient. And so what we were really able to do is just quickly, with the bronchoscope and the tracheostomy tube loaded, we were just able to actually appropriately place it and confirm visualization of the carina within a matter of seconds. And so I think, if you have the ability to do that and the tools are readily available, that's great. And another pearl there is, I guess, if you have a freshly placed trach, it's not a bad idea to have those tools readily available if an emergency occurs. But then also just knowing that blindly trying to put a tracheostomy tube in versus going from above and doing a traditional intubation is oftentimes going to lead you astray. So that's kind of like my approach. I don't know, Christina, what your thoughts are on that, and if you have any other pearls you'd like to contribute.
Definitely. So I want to highlight, because I think that's so important, and a lot of trainees, I think the initial instinct is like, oh, it came out, just put it right back in. But that risk of creating a false lumen is so important. And I think, people forget too, right? Someone has a trach, but you can intubate from above. So definitely that could be, definitely needed in these type of situations. And I think just going back and like whenever signing out a patient, right, you always want to know like what size is the trach, but how long that they've had the trach. These are important things that we need to include any type of sign out. So just wanted to comment because I really think that your teaching points are very well taken here.
Yeah, I love that. And I'll add we should do a whole other episode about trachs for sure. But like the other piece of information you on is why did they get it, right? Because if they had a laryngectomy and there's no connection from mouth to airway, and now the trach comes out, you're in much dire situation than this was just a trach for respiratory failure. You can always intubate from above. And then you mentioned loading the trach on the tube. I mean, this is great. This is references our past conversation too. It's like you should know your scopes and how they load, right? So some of the glide scopes actually have a little attachment to load an ET tube on it. You may use different disposable scopes. You may use different regular fiber optic bronchoscopes, but knowing how to load on your trach tube or your ET tube before, so you have a good view, and then you can just slide it right off, making sure it's lubed up appropriately and that you have good manipulation of it.
Yeah, there's one kind of cool trick that I really like with the disposable scopes. And, as pulmonologists, we have to kind of, bash on the disposable scopes. They're not as good as a fiber optic scope, blah, 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 blah. But like, there's one thing that's great about them, which is they're disposable, meaning you can break them. You don't care. And so occasionally you'll be in a situation where like, you don't know if a trach is malfunctioning. So you can put a bronchoscope in through it. You can confirm the anatomy. And now maybe you're like, wait a second, like I actually want to use a longer trach, like an XLT trach. So I want to take this one out and put a new one in. But wait, how can I do that? Because how can I swap them? Well, what you can do is you get your scope in through the old trach, you get the view you want, and then you take out your trauma shears and you cut the bronchoscope. And then you can take the old trach off, and then you can just slide a new one in. So you've basically turned a disposable scope into an exchange catheter. Don't amazing. Try this with your $40,000 fiber optic scope, though. Otherwise, you'll be in a lot of trouble.
Yeah, Nick told you to. You can do it. It's fine.
That's right. But send your bill to Critical Care Time.
Right.
Oh, no. Yep.
Oh, that's great. Man. All right. Well, I'm glad we talked through those two cases. Let's dive into our next case so we can talk about another bronchoscopic emergency. So you have a 50-year-old man who comes to the emergency department from the dentist's office. He lost a crown during a dental procedure. He's not in any distress, but his breathing just hasn't felt right. And so they decided to send him over here to the ED. When you take a listen, he has focal wheezes over the right anterior chest, and his chest radiograph shows a metallic density in the right middle lobe. So we're worried that he aspirated this crown. So what are we going to do next? So, I think this comes up with all pulmonologists. This is like akin to the GI conversation of what comes out of places it's not supposed to be in. I should say I've always been very lucky to train in places with really great IP. So my personal extraction has been pretty limited. That being said, I have taken out a blood cast plug that essentially made the entire lower lobe airway tree that came out on a deep suctioning of somebody who had focal aspiration. We'll talk about mucus plug-in and lobar collapse in a minute. You guys ever taken anything out that was particularly memorable?
Well, so this case actually is a real case that a guy who had a dental crown aspiration. I trained at a place that didn't have IP. So we got to do more of it. I took out a pistachio shell from somebody once.
Ooh,
where he could remember when it happened. It was like 5 years before. One of my colleagues took out, those capsule endoscopy things.
Yeah.
It's like a pill they swallow and it goes through the GI tract. Well, somebody like coughed as they were swallowing it. So then when they hooked it up to like the screen, what they saw was like branching airways.
Oh my goodness.
And the GI docs were like, nope, that's not what we're supposed to see. So they called Pulm to take it back out. So I've had a little bit of experience with this. I think depending on where you work and what you do, you may have more or less. I have a colleague whose dad is a pulmonologist in Taiwan, where they invented boba tea, and he's taken out boba like hundreds of times.
Yeah.
So he's probably the world's leading expert in removing that particular thing.
Boba extraction.
Yeah, I think this is a situation that comes up, not infrequently, probably more often in kids than in adults. I don't really know anything about kids, but a couple of useful points here. One is, the strategy for getting it out depends completely on where is it, what is it, how wedged in is it, and sometimes you can have all the right tools, and it's just not going to happen with a flexible scope. And so, about, depending on the literature you read, 15 to 25% of the time, you need rigid bronchoscopy and IP to do this. Occasionally, they even need surgery to do this. So no matter how good you are, you will not always succeed at removing foreign bodies. Maybe we should even take a step back and say, when do you need to remove foreign bodies? So I think this is a really important question, like sometimes, it's kind of it's like almost it's not quite an elective procedure, but it's like an urgent procedure, as opposed to other times when it's like truly emergent. Somebody has a whole lung down, they're having significant shunt physiology, and they are extremely hypoxic as a result. That's an emergency, as opposed to this case where the guy's got some focal wheeze, and obviously, he's got $1,500 worth of gold sitting in his right middle lobe. You want to get that out for him, but like that's not quite the same urgency, right? And I think that's one key decision point. Urgent versus emergent.
Yeah, absolutely. And I think, the other key thing for people to understand is exactly what you said, is like the difference between your flexible and your rigid scope, right? We're mostly talking about flexible bronchoscopy here. That's mostly what we're doing in the ICU and Palm. You have a flexible fiber optic scope. You're using the native airway as your guide and channel, and then you may have a working channel through it that you can put some tools through. For this type of thing, you need a big working channel. So your small, mini, flexible, disposable scope's not going to help at all. You need something that you can thread a pair of forceps through, or a grasper or snare through, that you can get around this object. And then usually if the object's that big, then you're going to be pulling the whole scope out to take it. And if that is a major concern, that's often my threshold to say, like, I need a rigid scope. If I am going to be really worried about the patient being sick and then taking my scope out with something, I think about this usually when I'm suctioning and I have a big collapse. But if you had an aspiration, then I say, you know what, I really want a rigid scope where I actually have a tube that's in there that's acting as my airway. I can work through it. It can take all the time in the world to take something out. If I have to pull the whole scope out with the device, I have this airway that's still preserved. And that's what I'm calling. A colleague was trained in that.
Yeah, exactly. I think that's a great point. I think the other thing too is that sometimes people are wondering, like, should you sedate, paralyze, intubate, or not? And I think that there's kind of two sides to that coin. On one hand, the person's cough is probably much more effective than any tool that you're going to put through the scope. So giving them the opportunity to cough and help you is probably a good idea. Sometimes that won't be an option. Like if somebody's in respiratory failure and they aspirated, that's a very different story. Sometimes you'll see this, like somebody, codes pre-hospital, they get intubated, but they lose some teeth in the intubation and they've aspirated some of those teeth. So now they have an endotracheal tube and they have teeth out in the airway and they're hypoxic. That's a situation where, well, it would have been nice to have them cough and help you, but they can't. And there it's a little bit harder because now you might be in a situation where maybe you can go through the tube, you can grab the tooth, but now you might have to take the tube out to get the tooth out with it, right? It may not fit through the endotracheal tube. So you have to be pretty flexible under those circumstances, and sort of, again, having a team working with you where you can say, all right, I'm going to take this out, and then somebody's going to have to reintubate.
I think I just want to chime in real quick. This does remind me of our, for those of us that listen to Critical Care Time, the episode 14 that we did on massive hemoptysis with Dr. Warren, who's an IP physician, and kind of like that idea of teaming up with IP. Really, like, all of the cases we've discussed thus far, and likely the cases we'll continue to discuss here, one of the big takeaway points is the idea of a team. You really have to check your hubris at the door. Really from top to bottom in critical care, but especially in these situations where, having anesthesiology or IP come up and help you, or calling a surgeon to come help you. At the end of the day, these are, again, stressful situations where having those hands, and not just necessarily random hands, but hands that bring unique skill sets to the table, can be in the best interest of the patient. So I think that's, to me, what keeps ringing loud and clear in my mind.
Yeah. And I think if you are training in a place like that, you should be asking yourself, like, what knowledge can I give them to make their job easier with my skill set? Right. So it's like, oh, okay, you're here. I can't do this, but I'm in the right middle lobe. I'm in the, we're in the medial branch here. I see it. It's not obstructing. I think they're ventilating, some data that you can say, I've gotten to this point, but I'm actually passing this off and you can help me out now.
Okay, I think we did a really great job of covering kind of foreign body retrieval. Talked a little bit about the tools that we might use, approaches, considerations. I'd like to kind of continue our conversation. And Christina, I wanted to pitch a case to you and kind of see how you'd approach it. So we'll say we have a 65-year-old lady with a history of COPD. She's been intubated for the last 3 days due to a community-acquired pneumonia. Her oxygen requirements are improved with antibiotics, so that's awesome. Her secretions are copious and tenacious, but it seems like maybe things are moving in the right direction, possibly. But then as time wears on, you notice that she's requiring more and more suctioning, and then all of a sudden she desaturates to 80%, despite a marked increase in her FiO2 to 100%. And then you take a look at the ventilator, and the peak pressures are going all sorts of crazy. Christina, what's going on, and what can we do about it?
Yeah, thanks, Iris. And I think this is such a typical case that that the four of us have seen, and a lot of people listening today will have seen as well. And I think that one thing that I'm thinking of, right, this is where you have to go to the bedside. You have to look at your patient. You have to look at your monitor, and you have to look at the vent and seeing what's happening. So understanding, seeing the peak, but trying to get the pressure, and then go down the algorithm. Is this more of a resistance problem? Is this more of a compliance problem? But in this specific case, I think some things that you brought up are, she's requiring suctioning every hour. They're copious and tenacious. So I'm really going to be thinking of, like, is this a mucus plug? And does she have an underlying lobar collapse? That's high on my differential. Someone, though, who's also been intubated and is now requiring 100% FiO2, you always want to rule out pneumothorax as well. So this is someone, right, team's ordering the chest x-ray, but it's going to take a few minutes to get there. So having someone, either yourself or having a team member coming in and just doing a bedside POCUS, and seeing, like, is there actually lung sliding, to make you feel that their pneumothorax might be less on the differential. But this is someone who I'm going to really try to get and do aggressive suctioning with, given concern for mucus plugging. And this is, RT will be there. You can sometimes I've had to actually disconnect them from the vent and bag and kind of apply that more pressure in order to help. But those are kind of things that I am thinking of right now based on this case. But interested, Nick, I don't know if you have any other thoughts, or I know you always bring in some type of obligatory animal physiology. So
That's
anything
right.
useful to add at this point?
Yeah, so I think I agree with everything you said. You want to make sure this isn't a pneumo. You want to try suctioning. I think suctioning, the inline suction, is great, but unfortunately, it's blind, right? And so the suction catheter tends to go to the lower lobes, maybe the middle lobe. It's not going to do a great job in the upper lobes. And so oftentimes, what happens if somebody has an upper lobe collapse, you're not going to be able to fix that with suctioning through the inline suction catheter. So this is a situation where the bronch can really help you. The fun animal physiology fact, and you're right, you know me too well, is that pigs, their right upper lobe doesn't come off of the right main stem. It comes directly off of the trachea, right? And so if pigs are intubated, the endotracheal tube often blocks the right upper lobe bronchus, so you get right upper lobe collapse. Now, that's a fun fact, but it turns out that like 1 to 3% of people have the same physiology as pigs. It's called a bronchus sui, right? French word for pig, or a tracheal bronchus, if you want to be, don't want to be all French about it.
Less pig-centric.
Right. But that's right. no name calling here. But the point is that, some number of people, especially like after surgery, they'll have a routine surgery, they'll be intubated, and then they'll be hypoxic and they'll have a lobar collapse. And the reason for this is because their right upper lobe didn't read the textbook and it's connected to the trachea. And if that tube is above the carina, it might still be blocking that. So the tube can be appropriately positioned and still cause lobar collapse. So this is a situation where it's great to look with a bronchoscope and just see what their anatomy is. I would say I find one of these pig bronchi in a post-op patient maybe like once a year. And, I always feel like very proud of myself and celebrate. And, everyone thinks it's probably insufferable for the next 10 minutes.
Yeah. And if you think that people are not bronching pigs, this happened. One of my best friends does research on airways things. And he was like, yeah, I had to fly to Detroit to bronch some pigs. Well, yeah, that sounds fun. One point I'm making these situations is that I feel like oftentimes when someone's on the ventilator and they're on a lot, people will say like, oh, they're on so much requirements, we actually can't bronch right now. If you're doing a bronch for diagnosis of infection, that is like the opposite of what they need in this situation. So if you've seen this collapse and you think there's a new mucus plug and the lobe was up and now is down, they're on 100%, but they need that out. And so this is your time where you're saying, okay, maybe I have to bag them up. Maybe if I'm confident on this diagnosis, it's time for me to take a look. And it doesn't matter if it's 2 a.m., time to get the bronchoscope and go down. And you want to just make sure you're using the right bronchoscope, right? So these are big, thick, tenacious plugs a lot of the time. We want the biggest channel that we can get. We should look at what ET tube they have or what trach they have. And we should take our therapeutic scope if we have one available. This is not the time to use your small small scope just to come down and take a look, because you're probably not going to get up that tenacious plug that's there.
So, Nick, I think your interest in physiology, of course, they expand beyond the pig and other animal models. Is there kind of a principle here that we can apply to why you might want to use that larger?
Yeah, I think Hagen-Poiseuille's law has entered the chat here. Just remembering that, that the flow through the working channel is going to depend on the radius to the fourth power. And so having a slightly bigger working channel will increase how much suction you can apply by a lot. So it really makes a big difference. Use the biggest scope that you can when your goal is to get rid of thick, tenacious secretions.
Love it. I'm just teaching in the first year physiology course right now, and I think Christina runs there. So Poiseuille's law is coming up all the time. I love that we're talking about it when we're in bronchoscopies also.
Right. Usually it's brought up in the context of catheters, but matters other places too.
Yeah, absolutely.
Well, such great learning points so far. And I know that we still have time for a couple of other cases. So one that I've seen for patients that I've taken care of with underlying structural lung disease are CF. So I'm going to propose this case. So 25-year-old gentleman with cystic fibrosis who's intubated for respiratory failure and suddenly is developing copious bright red blood from the endotracheal tube. So I think overall concern for underlying hemoptysis. And I think, each of us have on our respective shows have done an entire episode on massive hemoptysis, hemoptysis in general and approach. So some things I'm just thinking of right now before I pass it on, because I'd love some insight from you is, how much amount of blood that's being suctioned from the endotracheal tube is going to be important. Color of blood that I mentioned, is it bright red, dark red, or purple? Any clots, any underlying pulmonary cardiac history, and any use of anticoagulation or antiplatelet therapies. But as I am kind of thinking of this, Firth, I want to see, what are you thinking of as far as pre-bronch interventions? Are we going to try to bronch this patient? Are we going to try to send them down for imaging? What are we going to do going forward?
Yeah, I love this. This comes up all the time. Super important one to talk about. When I think about bleeding and bronchoscopic emergencies, I do want to say that there are kind of two flavors of this. One is the patient who comes in with massive hemoptysis, where I'm going to have to try to figure out where this is going on and then think about intervention. So localization, stabilization first, localization, intervention is how I think about those. And then the second that will come up that has some similar principles is you are bronching someone and they start bleeding, right? And so people think about this often with transbronchial biopsies. I'll say that the worst bleeds I've had bronching have been with BALs, which we do all the time, willy-nilly. So you need to know how to manage a bleed if it happens while you're bronching someone. If someone comes in with massive hemoptysis, like this patient seems to, they have cystic fibrosis, I'm really worried they could have a bronchial artery bleed, then stabilization first and then localization. So first thing I want to know is, how sick are they? And part of that is how much blood is coming up and can they manage it, right? So if it's just a bit of blood and they're coughing, a lot of times their cough can be really helpful. Obviously, we need to suppress it over time. But if they're clearing their airway, they're maintaining their airway, maybe have a little time to do a CT angio to localize where I'm at. If they're hemodynamically unstable, if they're respiratory unstable, then I need to protect their airway right away. And then I need to go in and see if I can localize this lesion. We talked about in our massive hemoptysis episode the use of nebulized TXA, which is really like a revolution in hemoptysis in the last few years. Like we just didn't have this when I was in residency, and now we have it and it works super well. And I highly encourage people to use it. It's very safe. The data is great. So nebulized TXA, I will say in a massive situation, it's probably not going to salvage, it's not going to right the whole ship, right? So you still need to do everything else well. And then if someone is really not oxygenating well, right, you have to think about protecting their lung. And so this can be a little counterintuitive, so it's worth doing. If you know where the bleed is, like this patient, they have tortuous bronchial arteries on one side, or you get an x-ray and it really looks like it's right-sided, you may want to put that lung down. Now, their oxygenation might get worse because you're going to be putting all the blood that's going to this lung that's not ventilating down there. But what your goal is in that is to protect the blood from spilling out into the other lung. And you need to do that till you can get a good airway in, and then go in with your scope. And my first thing is just trying to localize where this bleed is so we can figure out our next steps. But that's just the beginning of it. Cyrus, I'm curious, what you kind of do next once you're there, once you're bronching someone and they're having this bleed, and what we can do to try to help them out.
Yeah, so no shortage of sphincter tightening experiences on this episode. So this is another one that is, certainly, in hindsight, it can be fun to manage, but while you're doing it, it can be pretty terrifying. And so I love kind of your approach initially. I think all of us are like, we worship at the altar of TXA when it comes to a lot of different utilizations. Now, once you're in there and once you've sort of you're committed to using the scope, there are a few different things you can do. I think recently chilled or cold saline has sort of come under fire in terms of how efficacious it is, but a lot of us will still do that up front. It's a pretty easy intervention, and sometimes you do get some vasoconstriction that can be useful. Another thing, kind of similarly, can be effective. Sometimes it's not as effective as it sounds in theory, but topical epinephrine, so pushing like the 1 to 100,000 concentration of epinephrine at a site of bleeding. And this can be these kind of interventions I'll say can be particularly helpful if, for example, you're in the bronch suite and you've just done like a endobronchial biopsy with forceps or whatever, and so where the bleeding is almost certainly coming from. You can visualize it pretty easily, but recognize that when you go down and there's just a lot of blood and it's a very bloody field, it can be very difficult to figure out, oh, okay, I'm just going to squirt a little bit of cold saline on this little point, despite the fact that there's blood everywhere. And so like a phrase that I use almost like every episode we record is that the fog of war is very thick in the ICU, and that doesn't change when you're bronching someone, for example, in a situation like this. So, suppose you can isolate kind of, David, as you were suggesting, like, and you kind of maybe, let's say you have an idea as to where the bleeding could be coming from. If you'll recall, like, again, from the episode that we recorded, and I know from, previous discussions you guys have had, there are certain things you can do to sort of up the ante. And so one of them might be, using a bronchial blocker, which oftentimes in theory sounds better again than it is in practice. They can be difficult to kind of get those things lassoed properly and into the right space. But if you have an endotracheal tube, that can help kind of protect the airway and give you a little bit of time to do something like that, if you so choose. The other thing you can kind of do, which is interesting, is we talked about this previously, is like if you actually selectively intubate the affected side, and then you take like a tamponade balloon, like a CRE balloon or something like that. Usually this is something you might do with an interventional colleague. That's a way to actually direct that balloon or that tamponade device exactly where you need it with kind of scope visualization. And then you can back out and you can either have the endotracheal tube sitting in the trachea, or you can divert it potentially to the unaffected side while you've tamponaded the affected side. So that's an option. And then moving again towards more IP type stuff that again we would call for help for, using a cryoprobe can be really helpful. Especially like one of the issues with TXA is that sometimes you can get airway casting, and so you have to figure out, okay, how am I going to get this out? Well, you can try to just suck it out, or you can try to grab it out, but using a cryoprobe can be really nice because that clot will actually adhere to the blood. I'm sorry, the clot will actually adhere to the probe, and you can kind of pull it out in larger chunks. So that can be really helpful. Also using like a big trach suction, a large bore trach suction is another thing that you can use as an adjunct. So yeah, lots of different things you can do. I don't know, Nick, if there's anything else you'd add to that compendium of options there.
Yeah, I think you hit all the nails on the head there. The one thing maybe I'd add is just that remember that you can direct to the affected side in order to do interventions, or in a pinch, you can use your bronchoscope to direct to the unaffected side in order to sort of protect it. So if somebody has a significant bleed on the right side, you can drive your scope down the left main stem. You can push the endotracheal tube with it and then inflate it, maybe inflate it with more air than you normally would, with a goal of keeping blood from getting from the bleeding side into the unaffected side. Now remember, this is, you have to lower your volumes. You may have significant shunts. Like, it's not a perfect solution, but it's a skill that you can do. And it's a skill, to David's point earlier, you can hopefully do blind. Right? Even if all you're seeing with your scope is blood, if you can navigate left or right, you can probably deliver the tube where you need to. And so potentially a life-saving maneuver that buys you time, maybe for your IP colleague to get set up, or for your IR colleague to do a procedure. It's not your first step, but it's a great salvage step.
Yeah. Yeah. And that muscle memory is super helpful. And so I'll say, if a patient comes in and you find that the bleed is really localized, or if you're doing a procedure and they start a bleed and you're like, oh, I know I just lavaged in the right middle lobe, or I'm in the transbronchial in the right lower lobe, keep your scope right where it is, suction, 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 as long as it's not overwhelmed. at some point you have to come back to the trachea, the carina, and make sure blood's not filling the rest of the lung. And if you're not controlling the bleed with your suctioning there, then it's time to do next steps and take control. But if you're maintaining suction, even if you have a lot, I've had 500 cc's come out, but it's not spilling over. Sometimes you change for a therapeutic scope, but you have to get back to where you were pretty much through a red phase, right? And then be calling everyone to come in. But as long as you are suctioning and maintaining that the patient's oxygenating well, ventilating well, and it's not overflowing everywhere else, do that until you can think about your next steps. And then I'll just say, as someone who doesn't place balloons, but, will have IP come and help, one, localize so that they can come weave it in. There are different types of balloons. It could be going through the ET tube, around the ET tube. But then the things I want to know for them is, where is the balloon? And then how much does it need to inflate to be obstructed? Right. So if later that night that balloon is deflated and then all of a sudden they come, I'm like, okay, I know that they inflated with saline or they used air, and I need to put in 12 cc's to actually have a good obstruction. So these are like my emergency management for later.
Great points. All right. Well, one more case to get onto. So up until this point, we've really talked about places where the bronchoscope is therapeutic largely. You can do therapies via a bronchoscope, but I think there's a really important category where the diagnosis itself is really valuable, that there are diagnoses that you can only make using a bronchoscope that can profoundly affect treatment. So let me give you a case, David Cyrus. So you're assuming care of a young man with acute hypoxemic respiratory failure. He was healthy until a few days ago when he developed cough, shortness of breath, and dark urine. Hint, hint. He presented to the ED and was so hypoxemic that he required intubation. His labs are notable for acute renal failure with a creatinine of 3.5, previously normal. You note bloody urine in the Foley bag. So what could be going on here, and how can bronchoscopy help us?
Yeah, I love this. So this is my brain is tingling for one of my favorite categories of syndromes is that we have our pulmonary renal syndrome, right? So something's going on in the lungs. It seems like it's bleeding in the lungs, and then we also have renal dysfunction. A lot of people fall into this category because a lot of people who are sick with things in their lungs or sepsis also have renal dysfunction. But, when we're thinking about bleeding, then I think about these things. And in those workup, we have some ideas like vasculitis, small vessel vasculitis, that's affecting the capillaries in the lungs and causing a capillaritis, and then also causing glomerular inflammation. And so those are high up on our list. We could have Goodpasture syndrome, things that we want to rule out. At the same time, we could also have infections. Someone could just be really sick and have pulmonary dysfunction, and then also have renal dysfunction along with it. And when I'm worried about this, what I'm mostly worried about is, do they have diffuse alveolar hemorrhage? And what I want to know is, do they have capillaritis in the lungs that actually needs targeted therapy and is not going to get better with just antibiotics and conservative management? Are they going to need pulse dose steroids? Are they going to need plasmapheresis? And so when I am trying to decide that, we have our very well documented way of saying, look, this is at least diffuse alveolar hemorrhage. We can talk about in a second whether or not that means it's inflammatory or autoimmune capillaritis or a secondary cause. But we should know if this is diffuse alveolar hemorrhage. And what I'm looking for there is sensitivity within the alveoli and really that capillary bed that is actually getting worse over time with irritation. So if it's just bleeding in the bronchi, I expect that bleeding will clear as I start putting a lot of saline in. And if it's bleeding in the alveoli, as I put saline in, I expect that alveolar capillary bed to get more and more irritated and to get more bloody. So here we do serial lavage. You find a place, you wedge really nicely, you label your traps 1, 2, 3 in advance, right? I lavage in, a return comes back, and then I change out my trap, I lavage again, and I get another trap, and I do that 3 times. And honestly, I actually think the visual and the data is borne this out is pretty sensitive for that. If you're getting bloodier through this, then you have diffuse alveolar hemorrhage. If it's getting less bloody, then you don't. You probably have airway bleeding somewhere else. But you should also send them for cell count to prove that you actually have increase in your red blood cells on your serial lavage. And then once you have that, then you know this is DAH. And then it's up to you to decide clinically, is this primary DAH? Is this a capillaritis, a vasculitis syndrome? Or is this a secondary DAH with bleeding diathesis and just irritation of that alveolar capillary bed?
That's a perfect rundown on it. Yeah, I think, it's really important to remember that imaging can suggest DAH, but it's really a bronchoscopic diagnosis. And as you said, depending on the context, it may be a trigger for very different therapies, right? You may switch gears from antimicrobial treatment to saying, actually, this person needs like high dose steroids, maybe another immunomodulatory meds. So really important diagnosis to make early if you can. I think we should also think about some of those diagnoses that are really hard to make without a bronchoscope, like other conditions. So maybe just like for the sake of discussion, let's say that this person now has normal kidney function, but they have unexplained respiratory failure. Like, what other things sort of rise to the top of your list, Cyrus?
It seems like every day there's a new drug for something that's come out, and so with more and more drugs, you have more and more potential side effects, and one of those side effects can be acute eosinophilic pneumonia. And that can look very much like an infection in terms of fevers and hypoxemia, and so that's something to definitely have on your differential. The presentation is a little bit more it's actually quite a bit more impressive than like a chronic eosinophilic pneumonia, just so that our listeners kind of at least are familiar with the terminology, whereby a chronic eosinophilic pneumonia is quite a bit more indolent in most cases, but still you'll have kind of these opacities on a chest x-ray, and then you kind of get your CT scan that shows usually patchy infiltrates with some associated ground glass, versus an acute eosinophilic pneumonia where it's a much more impressive clinical presentation, and then they might have significant ground glass interlobular septal thickening. They may even have some central lobular nodules all throughout, so it can look infectious, but they're just not going to get better, and so you really need to make the diagnosis. A couple others that I'll mention. So prior to COVID, like what everyone in the pulmonary community was talking about was this diagnosis of E-Valley, or e-cigarette or vaping associated lung injury. It was like the hot topic at ATS, and then we like totally forgot about it because there was this like tiny pandemic that sort of came on and like changed the world.
Sucked all the oxygen out of the room, as it were.
As it were, right? But that doesn't change the fact that people are still using e-cigarettes or they're still vaping. And so interestingly enough, at least the last time I did a deep dive on this, there isn't like a characteristic pattern on CT that you're going to find. It can look kind of like a bunch of different things. But for example, if you have a lot of like monocytes or lymphocytes, for example, on your BAL, with very few neutrophils and like kind of not a whole lot of macrophages, that could potentially move you in that direction of E-Valley. And in that case, it's also particularly helpful to get cytology, because you might actually see some further evidence there. You might see some like foamy lymphocytes, I think, is one of the things that you might find. And so, that's certainly a consideration. I'll also kind of throw out here the lipid-laden macrophages of amiodarone toxicity, because that could also make someone be kind of sick. And in both cases, your history is what you're leaning on, but it wouldn't be out of the realm of possibility for someone to have just come back from a recent trip where they were around sick people. They were started on amiodarone not too long ago, and oh, by the way, they're an e-cigarette user. So like you can see very quickly how the history might shine some light on what's going on, and it might not. Then the final thing I'll mention is kind of this idea of an organizing pneumonia, which can be sort of cryptogenic, or it can be related to infection or many other things. And so that's really a histologic diagnosis that's going to require you to get tissue and get that tissue evaluated. So lots and lots of things that you can consider in addition to infection. I'm curious to hear what your guys' reaction is to that.
Yeah, I agree with what you said. I mean, I think I'm a little alarmed sometimes that people will do a BAL and not send a cell count. It seems to me like if you're exposing somebody to the risk of the procedure, you should make the procedure maximally diagnostically useful. Cell counts are cheap; they're widely available. I really don't think you should ever send a culture and not send a cell count, because you can miss things like acute eosinophilic pneumonia, and it's embarrassing, right? I mean, like I've seen cases where like a bronch was performed looking for infection, didn't grow anything, and then a second bronch was done 5 days later, and it was like 30% eosinophils, and it's like, oh man, that person was not getting optimally treated for all that time because they didn't send the test. So I would encourage our listeners to always send a cell count if you're going to do a BAL, because you will miss eosinophilic pneumonia if you don't look for it. And cytology can also help you with some of these other things. Like the cell count really tells you a lot.
Yeah. I always send a cell count of cytology on the first bronch for somebody. I mean, I just think it's good practice. And, we've all had that weird cancer case that presents and everyone thinks it's pneumonia. And then all of a sudden you have malignant appearing cells. So you got to look at them. We've touched on this here. No bronchoscopic episode would be complete with talking about when we're doing it and why, and then because we can encounter these emergencies. And I think it's our main diagnostic tool that pulmonary has to offer a lot of the time. Obviously, we're interpreting CAT scans for people as well, but we get a lot of requests for bronchoscopy for infection, right? Atypical infection, people who are immunosuppressed. We have a little bit of diagnostic nihilism in the field of pulmonary, I think, because we know that a lot of our community-acquired pneumonias, we only identify something 50% of the time, but there are a lot of patients where it's really important to get a diagnosis. So if you're on your pulmonary consult, you're going to get this question a million times. We want a bronchoscopy. Either someone's not getting better or the patient's immunosuppressed, they have something interesting going on. And I think it's helpful to know how useful is this tool, right, before I'm diving in? Because if it's only a couple percentage points, then maybe it's not that helpful. Someone has PCP, or you think they have PCP, but they've been on empiric therapy for a week. My bronch really doesn't have that much. They've already been on therapy for a week, right? And so we have to have some idea about how the utility of it is. So Nick, I'm curious, in your experience and from what we know sort of generally as a field, how often you sort of quote to people that this bronchoscopy is going to be helpful, it's actually going to change what we do or influence our decision making.
Yeah, so I think it depends a lot, like you said, on who the population studied is. I think especially in an immunosuppressed population, bronchoscopy is very high yield. I'll share a quick personal anecdote here, which is that when I was in fellowship, in pulmonary fellowship, my wife was in hem-onc fellowship, and so we got to work together sometimes. And I remember one time I was like she was consulting me, I guess, on one of her onc patients with respiratory failure, and her mentor, who was also the attending, was like very cynical. He's like, "Why do we do all these bronchs? It never changes anything. You're just going to put them on Vori anyway, blah, 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 blah." And I was like, all right, man, challenge accepted. Like, I will prove to you that this is valuable. So we actually went through like 5 years of bronchs in onc patients and looked at like 500 plus patients to see how often bronchoscopy was actually valuable. And you could define valuable in many different ways, right? Like, you could say, like, did you change management after the bronch? In which case, like 60+% of the time you do. That might be adding antibiotics, de-escalating antibiotics, adding steroids. Sometimes, your list of diagnoses before the bronch and your diagnosis after the bronch are very different, right? So something was at the bottom of your differential is now moved to the top, something like DAH. Sometimes it's something that wasn't even on your differential. And then occasionally, this is about 15% of the time, you see somebody where just a completely unexpected diagnosis was made. You thought somebody had one thing and it turned out to be something completely different. Organizing pneumonia, eosinophilic pneumonia, for example, or a couple of cases where somebody was diagnosed with mucor, right? And that's a diagnosis where it's like, you find mucor, that's a surgical treatment. You get a lobectomy, cure, antimicrobial treatment, likely to fail, likely to die. And so, to put that in context, right, that means that like, number needed to bronch to change management is about 2 in this high risk population. Number needed to bronch in order to find something really weird is like maybe 6 or 7. I mean, surprisingly high yield. Obviously, that's in probably the highest yield population, but I think my big takeaway from this was both I was right and her mentor was wrong, but also just that bronchoscopy can really profoundly change management. And so, don't hesitate to do it if you think there's a chance that there might be something weird going on.
Yeah, that's my philosophy too. I often say to the trainees, I'm like, why shouldn't I bronch this person? Because, just give me a reason not to. And I'm curious your guys' thoughts about this. One of my close colleagues and mentors here, Molly Hayes, and I have been doing this a lot more of these people in the ICU on high flow, where everyone's like, well, we can't do it. I've been doing a lot more bronchs on high flow. As long as they're not 100%, they're like 50, 60%, and I can sat them up well. I explain to them there's a risk of intubation, but I'm also like, we don't know what we're treating right now. And this will actually add a lot of diagnostic value in ruling things out. So I've been trying to be more aggressive about doing that.
And arguably, that's a population where it's almost like the most value, because potentially making that diagnosis to prevent intubation is like very high yield, especially in like immunosuppressed people.
Yeah, 100%.
Agree. No issues there. Well, guys, I think this was a really, really robust discussion. I love the sort of potpourri approach. I think we covered a lot of awesome material that I think our listeners will really appreciate. I don't know, Nick, do you want to take us through some general points, and then maybe, David, if we miss anything, you can sort of bring us home.
Great.
Yeah, so I think, we talked about a lot of different cases here. I think we covered 6 cases, but we can put them in a couple categories, right? So you can use a bronchoscope to place an airway, either through the vocal cords or replace a trach. You can also use it to confirm an airway. So that's a very important kind of emergent situation. You can also use your bronch to remove stuff. So foreign body or mucus plugs, that can be a life-saving maneuver. And then you can also, use your bronch to deal with hemorrhage, either to identify where it is or to potentially perform interventions to stop it. And then finally, remember that the bronchoscope is also diagnostically useful. And sometimes the most important thing that we bring to the table is diagnosing what's going on, so we're treating the right thing. And so lots of different ways where a bronchoscope can save you. I think it's really important to remember that having a bronchoscope is more than just having the equipment, though, that you have to know what you're doing. You have to have the broad differential, and you have to practice. And so, even if you've done a lot of bronchs in training, I think it's valuable to practice, airway sims. And if you haven't done a lot in training, it doesn't mean you can't use it. I think it just means you need to get some time holding a scope, doing as much simulation as you can with airways. That way, if the situation comes up, you have some familiarity. And then I think, just to echo a point that we made several times, it really takes a village. A team approach is important. Bringing in somebody who maybe is better than you with a bronchoscope, whether that's an IP person, pulmonologist, whatever, is really important. And, sometimes the collaboration is where the bronchoscope is most useful.
Yeah, I love that, Nick. I loved what you said was that people don't rise to the occasion. They sink to the level of their training. They don't sink to the bottom. They sink to what they're most comfortable with. And I think in the ICU and in emergencies is the time to not have ego, to be honest with yourself and others about where you are and what comes next. Like, I can intubate, but I have not done a ton, and I'm not the best person in the room most of the time, right? And so if there's someone who's really high risk, I often say, hey, why don't I manage X? I'm pretty comfortable with the bronchoscope. I can be ready at the hand if something's coming, but why don't you do first pass success? And having that dialogue and being open is, nobody has ever been like, oh, I can't believe you can't do that. Everyone appreciates an honest approach, and you get the best outcome for your patients.
And I think that is a perfect moment to end our show on.
Yeah.
Yeah, I think, to our listeners, you're gonna find this in both our feeds, so you can listen to this on the Pulm Peeps podcast or the Critical Care Time podcast. If you subscribe to one, subscribe to the other, because as you can see, we're the Flintstones and the Jetsons, right? I mean, obviously, if you like one, you're gonna like the other.
100%. Yeah.
Reminder to our listeners, you can go to our website and we'll have notes about this, so a lot of the things that we mentioned will have links. I actually published that case with the tooth, so you can see pictures of the gold tooth I took out.
I love it.
And lots of other fun things to find there.
That's great. Yeah. Thanks, guys, for taking the time to do this. For other listeners, Christina had to run off. So, she really enjoyed being here, but she had to go handle something, which happens to all of us in our academic and critical care time. But yeah, definitely go visit pulmonpeeps.com. Make sure that you're following both of us. Guys, I've been loving what you guys have been doing, and I've been listening along, and you're definitely one of my top feeds. So excited that we're doing this, and hopefully we can get another one coming.
Yeah, that'd be fun. Right back at you, by the way. We love your show. Our listeners should definitely subscribe to both. Check out pulmonpeeps.com and criticalcaretime.com.